Okay, so hello everyone. My name is Solitray. I'm a medical student in Geneva. So today I'm going to talk about disease management Visualiser. So this study is part of the GEMINI project, which brings together 19 organizations from 12 countries that collaborate to develop a digital twin of stroke focalizing on intracranial aneurysms. The way it works is that it models disease and its management. The aim is to reduce the burden of the disease, and the burden is represented as the surface under the curve of the modified ranking score over time. So the issue with scores and tools we use so far is that the variables interact. The variable interactions are not taken into account. So in the model, the variables are probability distributions, and to model probabilistic interactions, we apply the Bayes theorem. So we can map those interactions as displayed here. The differences between both maps on the left and on the right are on the left. It's a model. It models a single center data, and the outcomes is the probability of aneurysms rupture. So this graph is the work of Matteo Bellucci, published in 2022. And on the right, it models the data from multiple centers. The intention was to reproduce the same graph with the outcome being the probability of aneurysm rupture, but the inter-center data variability only allowed us to model the probability of rupture at a specific age. On the left, it is an Additive Bayesian Network, which means that all the variables are transformed as normalized discrete informations, allowing mixing binary, categorical, and continuous variables in the model. On the right, a mixed effect has to be used to correct for inter-center variability. So this process of applying the Bayesian theorem, normalizing the format of variables and inter-center variability is automatically processed by the R package ABN available to all on the graph. So it shows several factors represented as nodes and linked together by arrows. These arrows represent the interactions and interdependencies between the different factors. This type of graph is called a directed acyclic graph. So now that we understand the concept behind this model, let's move on to the example I would like to present you today. So this model is based on the Geneva cohort of 3,182 patients. So far we included 1,125 patients with reliable and complete data. Therefore, the models we show remains preliminary results. So we decided to focus on a very particular and frequent population, the ASIS populations. So the ASIS stands for patients diagnosed with asymptomatic saccular incidentally discovered solitary aneurysms. And in our cohort, we have 554 patients. We then collected data, and at 1 year, we had data for 478 patients. So those are the outcomes of all patients, and the mortality, we can see that it's almost 2%, but when we look into the cases that died, we actually see that the most of them died of other causes, so unrelated to the aneurysms. Therefore, we created the ASIS WUDOC cohort, which is the ASIS without death of other causes. So, after 1 year of follow-up, the results show that 90% of patients remain fully independent, 9% of patients had some disability, and 0.5% had mortality attributable to the aneurysm disease. So, applying the Bayes theorem, like presented by my colleague Alexandre, we use the cohort 1 year outcome probability as the prior, so the A, and the outcome given a particular location, condition, is here the outcome given the aneurysm location, the I, and the outcome given the location is the posteriori probability. So, on the right, this is a mosaic plot where the lines represent the prior outcome results, and the columns represent the probability of a patient having an aneurysm in a certain location. The rectangles represent the posterior probability of an outcome given an aneurysm in a location, in a particular location. So you can see that there are variations. The rectangles are not the same size, and in blue are those they are significantly different. So posterior circulations and distal aneurysms have a higher mortality rate than other locations. So this example illustrates how we can apply the Bayes theorem to our cohort, and now we can repeat this theorem with all the factors in our cohort in all the conditions we want to explore. So this slide represents the Bayesian network of the ASIS cohort. Each factor is represented as nodes and linked by arrows, showing the interdependencies that converge towards the red box, which is here the outcome at 1 year. That is the disease management map, because it integrates the initial conditions at diagnosis, the treatment modality, and the outcome, the probability, the resulting outcome, sorry. Here is a clinical tool that represents a disease management visualizer. So now the nodes contains the distribution of patients according to the different variables categories. It shows the full ASIS cohort without death of other causes. And starting from there, we can play with the graph. So we select patients with aneurysms in a high-risk equipoise location, so ACOM, PCOM, and PICA. And we can see that the distribution changed in all the nodes. In the situations, we can see that the two treatment modalities are considered equivalent. And now we can explore the patients treated by microsurgery. And we see that the probability of those patients to have a high aspect ratio aneurysm is small. In contrast, people treated by endovascular intervention are much more likely to have high aspect ratio aneurysms. By the way, high probability of excellent outcome, meaning modified ranking 0, at 1 year is higher for the endovascular treated patients. And microsurgical patients, as you may have seen, are more likely to have some disability and symptoms that may have a small impact on their productivity, but less probability of suffering a severe disability is observed for endovascular cases. So, in conclusion, the model developed with properly created data and displayed with the tool as we showed opens, we hope, an avenue to evidence personalized decision making. But as the cohort is still a sample obtained only in a single center, it is not yet proper for clinical use. It will require to be validated across multiple centers, the tools verified and uncertainty quantified at all stages of development, implementation, and use. So thank you to Geneva and Zurich team, and thank you to my mentor, Geneva. Thank you.